My name is Johanna Bendel, and I'm the Director of GI Oncology Research at the Sarah Cannon Research Institute in Nashville, Tennessee. I presented at ASCO 2016 a study on the clinical activity and safety of cobimetinib and atezolizumab for patients with metastatic colorectal cancer. We know that immunotherapy has fairly limited activity in patients with metastatic colorectal cancer. The only patient population that we've seen some activity of immunotherapy is in the patients with microsatellite instability. And for those patients, somewhere between 20 and 50% can have a good response and a durable response to treatment secondary to their high mutation burden, which makes them more responsive to immunotherapies. However, what about the other 95% of patients who have microsatellite stable colon cancer? So this study looked at combining a checkpoint inhibitor, the PD-L1 inhibitor atezolizumab, with a MEK inhibitor, cobimetinib. We've seen preclinically that MEK inhibition can increase the CD8-positive T cells in tumors as well as upregulate class I MHC, so that way you start to draw in the immune cells and start to activate the immune cells, which might prime the tumor in some senses for responding to checkpoint inhibitors. And we've seen preclinically that when you combine an anti-PD-L1 inhibitor with a MEK inhibitor, you see better tumor regression than either agent alone. So this was a phase 1b dose escalation study that looked at 3 dose levels of the combination of cobimetinib and atezolizumab in patients with solid tumors, and then looked at a dose expansion in patients with KRAS-mutated metastatic colorectal cancer. A total of 23 patients were enrolled in all who had metastatic colorectal cancer on this study. And what we saw for these patients is all but one had a KRAS mutation. We also saw that when we looked at PD-L1 expression for this patient population, it was fairly low, which was very consistent with what we've seen with colorectal cancers previously. And investigator-reported MSI status we knew for 30% of the patients who were all stable, and we didn't know at baseline about 70% of their statuses. Looking at safety of the combination, most of the safety events were secondary to cobimetinib-related AEs, including diarrhea and rash. We didn't see any significant immunotherapy-related AEs outside of what you would expect from a PD-L1 inhibitor. There were no dose-limiting toxicities, and there were no grade 5 events that were seen in this study. When we look at the efficacy of the entire patient population of the 23 patients enrolled, we saw an overall response rate of 17%, with 17% PRs. And for those patients that had partial responses, they all had fairly low expression of PD-L1. We also looked at the 4 patients in terms of their microsatellite instability status, and we know that 3 out of the 4 responders were mismatch repair proficient, both tested by baseline IHC and then confirmed centrally with NGS-based scoring. One of the patients we know that was a responder, we do not know the MSI status because we did not have tissue available to test. When we looked at the patients who did have partial responses, we saw that the partial responses were durable, and we still had 2 out of the 4 patients who were responders continuing response at the time of presentation. We also saw some patients with durable, stable disease over 6 months in length. We looked at progression-free and overall survival, but so far the data is too early to really say too much. We still have to wait for it to mature. But certainly we saw improvements in the 6-month progression-free survival and 6-month median overall survival compared to what we've seen with historical data with other agents that are used for the treatment of refractory metastatic colorectal cancer. When we look at the biomarker activity from patients who had biopsies on study, we can see that with the combination of cobimetinib and atezolizumab, we saw a higher population in the tumor of CD8-positive T cells when they were treated with cobimetinib and atezolizumab compared to baseline, as well as decreases in phospho-ERK, which suggest MEK inhibition. For one patient with clear cell sarcoma who was on a serial biopsy cohort, you can see both the activity of cobimetinib alone and then cobimetinib with atezolizumab, and you can see the gradual increases in CD8-positive T cells in the tumor over baseline with just cobimetinib alone, and even more with the combination of cobimetinib and atezolizumab, as well as upregulation of MHC class I, as well as increased expression of PD-L1. So what this shows us is that we are able to see immunotherapies work for patients with microsatellite stable disease when we combine a checkpoint inhibitor with another agent, in this case a MEK inhibitor that can upregulate the immune system and potentially prime these patients' tumors to respond to immunotherapy. We saw the response rate of 17%, And we also saw the 6-month overall survival of 72%, which is higher than we've seen historically with agents in the refractory setting. So based on these encouraging preliminary results, a randomized phase 3 study is now open and accruing, looking at the combination of icovamenib and atezolizumab in the patients with metastatic colorectal cancer to confirm better the data that we've seen in this study. Thank you so much.